Welcome back to The Deep Dive, your shortcut to surgical mastery. Today we're tackling a really critical area, one that demands absolute precision, total anatomical recall. We're doing a deep dive into the specialized surgical anatomy of the colon, rectum, and anus. We are aiming to pull every single detail from our source material to build really a complete mental map of this whole complex system.
Yeah, and it's arguably one of the highest stakes environments in, well, all of visceral surgery.
Yeah.
The margin for error, it's basically non-existent. A perfect oncological resection doesn't mean much if the patient ends up with a devastating permanent functional deficit.
Absolutely.
So to really master these procedures, you've got to know the fascial planes, the critical vascular junctions, and especially those incredibly delicate neural networks down in the pelvis. It's intricate stuff.
So our mission today is total information extraction. We want to move past just memorizing facts and really aim for genuine professional mastery. We need to know where every nerve runs, where every vessel connects, because as our sources keep hammering home, colorectal surgeons rely on these absolute anatomical certainties to preserve function.
Right, and just to give you a framework for the level of detail we're going for, we're discussing the anatomy as it relates directly to some pretty complex operations.
Yeah.
So on the colon side, that means things like segmental colectomy, appendicectomy, and that emergency standby Hartmann's procedure.
And then shifting down to the rectum and the pelvis, the real gold standards,
Yeah.
the low anterior resection, or LAR, and the definitive abdominoperineal resection, APR. And finally, getting right down to the anal canal, where we're dealing with high-risk, high-detail procedures. Things like internal anal sphincterotomy, fistulotomy, incision and drainage of perianal abscesses, and of course, haemorrhoidectomy.
It's a lot to cover.
It really is. So let's start right at the beginning with the foundational anatomy. What fundamentally sets the large bowel apart from the small intestine?
Okay, so the large bowel, or the colon, it's actually relatively short, only about 150 centimeters long. That's what, maybe a quarter of the length of the small intestine?
Much shorter, yeah.
But its capacity, its diameter, that's immediately distinctive. And it varies hugely. Down in the sigmoid colon, it could be pretty narrow, maybe 2.5 centimeters, thick wall, small lumen.
Right.
But then you get up to the cecum, and it can balloon out to a massive 7.5 centimeters. Much thinner wall there, too.
So that variable caliber is one key marker. But if you're a surgeon, maybe doing an exploration, and you need to tell small from large bowel quickly, the sources point to 4 really unmistakable anatomical identifiers. What are those?
Okay, yeah. Besides the larger caliber and the fact that the large bowel is often, much less mobile because of its mesentery or sometimes lack of one.
Fix and place more.
Exactly. We look for 4 key structures. These are the taeniae coli, the haustra, the plicae semilunares, and those little fatty tags called the appendices epiploicae.
Let's focus in on the taeniae coli. They seem absolutely central to the colon's whole structure, almost like internal guide ropes.
They're critical, absolutely. There are 3 distinct bands of longitudinal smooth muscle, basically gathered up along the length of the colon. They start all clustered together right at the base of the appendix, and they run that entire length. They only really merge back into a continuous layer when they hit the rectus sigmoid junction.
And you mentioned they have constant positions, which I imagine is invaluable for a surgeon trying to get oriented. Can you detail those 3 specific bands based on where they sit?
Sure. So the first one is the taenia libera meaning free. It's positioned on the anti-mesenteric side.
Opposite where the blood vessels enter.
Exactly. Opposite the mesentery. The second is the taenio mentalis. That one's down posterolaterally, and it's often where the greater omentum attaches, especially on the transverse colon.
Makes sense.
And finally, the taenia mesocolica. This one is posteromedial, so it's located closest to the mesentery itself where the vessels actually come in.
Okay. So it's the contraction of these bands that gives the large bowel its characteristic bunched-up appearance.
Precisely. Unlike the small intestine, which has a continuous longitudinal muscle layer all the way around, the taeniae are gathered. So when they contract longitudinally, they pull the colon wall inwards, sort of shortening it between fixed points. This contraction is what forms the haustra, those familiar saccular outpouchings you see.
The segments.
The segments, yeah. And internally, these outpouchings create shelf-like circumferential folds called the plicae semilunares. It's all a very structured system, really designed for slower transit and maximizing water absorption.
Okay, got it. Let's quickly list the 8 segments then. Cecum, appendix, ascending, transverse, descending, sigmoid, rectum, and anal canal. We have to start at that initial barrier, the gateway from the small bowel, the iliopsacral valve.
Right. Structurally, the valve is pretty simple, just
Yeah.
two sort of semilunar mucosal lips.
But functionally.
Absolutely vital. Its single crucial role is to prevent the backward reflux of, highly contaminated colonic contents back into the relatively sterile terminal ileum.
And its competence, whether it holds tight or not, can actually dictate acute pathology, can it?
It absolutely can. This is a critical clinical point. If you have a distal large bowel obstruction, say, from a cancer or a really bad stricture, and that ileocecal valve is competent, meaning it's working perfectly, holding tight.
It seals the system off.
Exactly. It seals off the large bowel, creating a dangerous closed-loop obstruction. The pressure builds and builds, and the cecum, being the widest part with the thinnest wall, basically becomes a pressurized bomb. Acute perforation is a very real, imminent danger.
Wow, okay. And if it's incompetent?
If the valve is incompetent, it allows the pressure to vent backwards into the small bowel. It buys some time, makes it a less immediately critical situation, but it's obviously still a very serious obstruction that needs dealing with.
Okay. Moving just distal to that, we hit the appendix, the source of so much acute surgery. What are its typical dimensions, and maybe more importantly, that variability in its position that can really confuse the clinical picture?
Yeah, the appendix. It's this narrow, blind-ended tube. Remarkably variable in length, could be anywhere from 2 centimeters up to 20 centimeters long.
Huge range.
Huge range. But it's consistently narrow, averaging only about 5 millimeters in diameter. And because it's quite mobile on its little mesentery, the tip can point almost anywhere. That's why the symptoms of appendicitis can vary so widely. The most common positions, sort of in order, are retrocecal, tucked up behind the cecum, the retrocolic behind the ascending colon itself, pelvic, hanging down into the pelvis.
Which can mimic GYN issues sometimes.
Absolutely. Then less commonly, subsacral, below the cecum, or ileocecal, right next to the terminal ileum. Its dedicated blood supply is the appendicular artery, which pretty reliably branches off the ileocolic artery.
Okay, now we shift down into the pelvis, where the rectum marks a complete anatomical transformation. It seems to lose all those signature features we just discussed for the colon.
Completely different beast, yeah.
Yeah.
The rectum is wide, it's freely distensible, and structurally, it's distinct precisely because it lacks the taeniae coli. And if you don't have taeniae, you don't get haustra or appendices epiploicae.
Right.
Instead, its internal structure is defined by 3 permanent transverse mucosal folds. These are known as the valves of Houston. There's typically a left superior valve, a right middle valve, and a left inferior valve.
And I can see how this connects directly to surgical assessment. These folds create natural curves, right? So their presence must impact how far away a lesion seems to be from the outside.
Exactly. This is essential for preoperative planning, especially with endoscopy. When a surgeon mobilizes the rectum during an operation, they're essentially straightening out those natural curves and folds. What that means is the actual post-mobilization length of the rectum is greater. So a lesion's measured distance from the anal verge often appears higher or further up after mobilization than the initial measurement suggested.
Interesting point.
And anatomically, the rectum is encased in this layer of pararectal fat. That fat contains the vital terminal branches of the superior rectal artery from the IMA and the associated lymph nodes. And this whole package, rectum, fat, vessels, nodes, is wrapped by a distinct layer of dense connective tissue called the fascia propria. That's a key surgical layer.
Okay. Finally, for this foundational section, let's define the anal canal structures precisely. We need to distinguish between the anatomical and the surgical canal concepts.
Right. So the anatomical canal is technically the mucosal tube that extends from the anal verge, the visible outside opening up to the dentate line.
Also called the pectinate line.
It's also called the pectinate line, yeah. This line is the critical transition point. Above it, the tissue has visceral afferent innervation. It's generally insensitive to cutting or burning, feels stretch. Below it, you have somatic afferent innervation, highly sensitive to pain, touch, temperature.
Like skin?
Like skin, exactly. Within the mid part of the anatomical anal canal, we find these 6 to 10 vertical mucosal folds. Those are the anal columns, or sometimes called hemorrhoidal columns. They contain the terminal branches of the superior rectal artery and the internal rectal venous plexus.
Okay. And the concept of the anal cushions seems central, both for normal function, for continence, and also for pathology like hemorrhoids. Help us define their structure and that dual function.
Yeah. The anal cushions are really important. They aren't just simple veins. They are 3 distinct localized areas of prominent, highly vascular subepithelial tissue. Think of them as specialized pads. And they are consistently located, primarily at 3, 7, and 9 o'clock if you're looking at the patient in the standard lithotomy position.
Which corresponds to right anterior, left lateral, and right posterior anatomically.
Exactly. Their normal physiological function is actually passive. They act like inflatable gaskets. They engorge with blood under normal resting tone, and this helps them function to precisely seal the anal canal shut. They're crucial for maintaining continence against flatus and liquid leakage, especially at rest.
So they provide the fine-tuning of continence.
That's a great way to put it. However, when these vascular cushions become pathologically engorged, stretched, and displaced downwards, well, then they become the core structures involved in the pathogenesis of hemorrhoids.
Okay, let's dive into the muscular core that controls all this highly specialized function, starting with the internal anal sphincter. It's involuntary, smooth muscle, and it's essentially a continuation of the circular muscle layer of the rectal wall, right?
That's exactly right. It's the thickened terminal end of the rectal circular smooth muscle.
Where does it actually end? And why is that lower border so critically important for the anal surgeon?
It terminates about 1 centimeter proximal to or above the distal edge of the external sphincter muscle, and the fascia and connective tissue that lie between the lower edge of the internal sphincter and the subcutaneous part of the external sphincter create this palpable and sometimes visible little depression called the intersphincteric groove.
Okay.
This groove is a primary surgical landmark. For procedures like low-risk lateral internal sphincterotomy for fissure, finding that groove allows the surgeon access to divide the internal sphincter fibers without damaging the crucial external sphincter.
Got it. And clinically, when surgeons are assessing things like low-lying tumors or maybe complex fistulas, they often refer to the surgical or functional anal canal. How is that defined?
Right, the surgical anal canal is a bit longer than the anatomical one. It extends approximately 4 centimeters upwards from the anal verge, right up to the palpable upper border known as the anorectal ring.
And what exactly defines that anorectal ring muscularly? What's meeting there?
The anorectal ring isn't a single distinct muscle. It's the palpable functional ring, formed where the uppermost fibers of the internal sphincter, the deep part of the external sphincter, and crucially, the loop of the puborectalis muscle all converge. It feels like a distinct muscular shelf on digital rectal exam, and it marks the functional upper limit of the anal canal for clinical assessment.
Okay. And then we have the external anal sphincter. This is the voluntary skeletal muscle component. Give us the precise innervation again for that one.
The external sphincter is under conscious control. It's innervated by the inferior rectal branch of the pudendal nerve. Remember, that nerve originates from the sacral spinal cord segments S2, S3, and S4. Keep those numbers in mind. S2, 3, 4 keeps the poo off the floor, as the saying goes.
Ah, nice mnemonic.
Any procedure, say draining an abscess in the ischial space or dealing with a fistula laterally, puts that somatic nerve branch at significant risk. Damage it, and you risk impacting voluntary continence.
Right. Now, let's look upwards slightly to the pelvic floor itself. We have the main levator ani group that's the iliococcygeus, pubococcygeus, and puborectalis, plus the smaller coccygeus muscle posteriorly. The sources really highlight the puborectalis as the absolute linchpin of fecal continence.
It absolutely is. You could call it the workhorse of continence. The puborectalis muscle forms this deep U-shaped sling. It originates from the back of the pubic symphysis on both sides, loops posteriorly, wrapping tightly around the anal canal at the level of the anorectal ring. At rest, it's tonically contracted, meaning it's firing subconsciously all the time. This constant contraction creates a strong anterior horizontal pull.
Pulls the rectum forward.
Exactly. It kinks the rectum forward, creating a sharp angle, the anorectal angle, typically around 80-90 degrees. This angle mechanically obstructs the rectal outlet, effectively pinching it closed. This sustained, largely subconscious tension is what ensures gross fecal continence, preventing stool from just falling out.
So defecation absolutely requires relaxing that muscle.
Yes. Voluntary defecation requires conscious relaxation of the puborectalis sling. That relaxation allows the anorectal angle to straighten out, opening the outlet path for stool to pass.
Okay. And the other components of the levator ani group, the iliococcygeus and pubococcygeus, their function is a bit more general, is that right?
Yeah, they form the broader muscular diaphragm or hammock of the pelvic floor. They provide the general structural integrity and the crucial uplifting mechanism of the pelvic floor, especially during increases in intra-abdominal pressure like coughing, sneezing, or lifting. The iliococcygeus is the more lateral sheet of muscle. It rises from the ischial spines and the fascia covering the obturator internus muscle, and it inserts onto the lower sacrum, the coccyx, and the anacoccygeal raphe, that midline fibrous band.
And the pubococcygeus?
The pubococcygeus lies more medially, internal to the iliococcygeus. It also starts from the posterior aspect of the pubic bone and the nearby fascia, and it inserts similarly onto the coccyx and raphe.
And the pubococcygus has this unique medial arrangement that actually defines the pelvic outlet itself.
That's right. Its most medial fibers specifically sling around and support the pelvic viscera as they pass through the floor, namely the urethra, the vagina in women, and the anus. This central opening formed by the medial pubococcyx fibers is called the levator hiatus. The integrity of the fascia and muscle supporting this hiatus is vital. When it weakens, often due to childbirth trauma or chronic straining, this becomes the fundamental anatomical defect that underlies many forms of pelvic organ prolapse, cystosoles, rectosoles, uterine prolapse.
Okay, let's try and synthesize all this muscular anatomy into the actual mechanism of defecation. It sounds incredibly complex, a highly coordinated function involving the colon, rectum, pelvic floor, and both sphincters. The central circuit seems to be the recto-anal inhibitory reflex, the air-air.
The rear air is really one of the most elegant neuromuscular circuits in the body. It's an intrinsic reflex. When stool arrives from the sigmoid colon and causes rectal distension, this stretch triggers the reflex, which simultaneously causes two actions. First, it triggers a contraction of the voluntary external sphincter, sort of a preparatory hold-on signal. But almost paradoxically, it also causes a transient relaxation of the involuntary internal anal sphincter.
Why? Why relax the internal sphincter momentarily if you're trying to hold on?
That's the clever part. That brief moment of internal sphincter relaxation allows the very top layer of the rectal contents, whatever is causing the distension, to momentarily descend and make contact with the highly sensitive mucosa of the upper anal canal. This region is called the anal transition zone, or ATZ.
The sampling zone.
Exactly. The ATZ can then sample the nature of the contents. Is it solid stool, is it liquid, or is it just gas? This crucial sensory information gets relayed to the brain. The brain then integrates this with social context and decides whether it's appropriate to proceed with defecation by voluntarily relaxing the external sphincter and puborectalis, or if it needs to maintain continence by overriding the urge and keeping the external sphincter contracted.
That's fascinating. So what's the clinical relevance when this RAR reflex fails or is impaired?
Well, impairment of the air leads to significant problems, usually functional incontinence or potentially severe dysmotility or constipation. Our sources indicate this impairment is commonly seen after severe obstetric injuries that damage the pudendal nerve supply. You also see it in inflammatory conditions like severe proctitis, sometimes after extensive surgical mucosectomy in the upper canal, which removes the centroreceptors, and pathognomonically, it's absent in Hirschsprung's disease. In Hirschsprung's, the segment of bowel lacking ganglion cells cannot relax in response to upstream distension, so the reflex just doesn't happen.
Okay, let's switch gears completely now and map out the vascular architecture. This requires thinking about the two great arterial territories based on embryological origin, the midgut and the hindgut supply.
Right. The dominant supply for the midgut is the superior mesenteric artery, the SMA. It's usually the larger of the two main colic arteries, and it originates quite high off the aorta, typically around the level of the first lumbar vertebra, L1.
And its territory covers.
It supplies everything derived from the embryological midgut. So that's the distal duodenum, all of the jejunum and ileum, the cecum, the appendix, the ascending colon, and usually the proximal two-thirds of the transverse colon, right up to around the splenic flexure. Its main colic branches are the middle colic artery, the right colic artery, and the ileocolic artery.
Now, I understand the ileocolic artery is usually the most anatomically constant of those branches, but the sources really caution about significant variability in the others.
That is a crucial point for any surgeon operating on the right colon. While the ileocolic is fairly reliable, the origin and branching patterns of the right colic and middle colic arteries are highly variable. Studies show significant deviations from the textbook anatomy in up to 20% of patients.
So you can never just assume where they'll be?
You absolutely cannot assume. You have to meticulously dissect and identify them in each individual case.
Okay. Then we have the inferior mesenteric artery, the IMA, supplying the hindgut territory.
Correct. The IMA arises significantly lower down the aorta, typically at the level of L3, which is usually about 3 to 4 centimeters above the aortic bifurcation into the common iliacs. It supplies the embryological hindgut structures. That means the distal part of the transverse colon, roughly the distal third, the entire descending colon, the sigmoid colon via specific sigmoid artery branches, and the upper part of the rectum. Its main named branches are the left colic artery and the sigmoid arteries. After giving off these branches, the main trunk of the IMA continues down over the pelvic brim, where its name changes to the superior rectal artery.
Which is sometimes still called the superior haemorrhoidal artery in older texts.
You still hear that sometimes, yeah. Superior rectal is the more standard anatomical term now.
Okay. Now, the viability of the colon, especially during surgery when you might ligate one of these main arteries, relies heavily on backup arterial highways connecting these two major systems. We have the marginal artery of Drummond and the arc of Riolan.
Yes, these anastomotic arcades are vital. The marginal artery of Drummond is the primary backup system. It's essentially a continuous arterial channel formed by a series of connecting arcades that run parallel to the entire length of the colon, right along its mesenteric border. It connects the terminal branches of the iliacolic, right colic, middle colic, left colic, and sigmoid arteries. It's absolutely vital for maintaining colonic viability if one of the primary feeding arteries, like the IMA or a major branch of the SMA, needs to be ligated during surgery.
But its continuity isn't always guaranteed, is it?
That's the catch. While often continuous, the marginal artery's path can be tenuous or even interrupted, especially at the watershed areas near the splenic flexure, connecting middle and left colic territories, and down near the rectosigmoid junction, connecting the last sigmoid to the superior rectal.
And that's presumably where the second anastomosis, the arc of Riolan, might become critically important. It's like the plan B of the colonic arterial system.
That's a good analogy. The arc of Riolan, also sometimes called the meandering mesenteric artery, is a less consistent, deeper, more central secondary anastomosis. When present, it typically forms a direct link between the proximal left colic artery from the IMA and a branch of the middle colic artery from the SMA. It often only becomes significantly enlarged or dominant and easily visible when there's underlying chronic stenosis or occlusion of either the SMA or, more commonly, the IMA, forcing blood flow through this alternative route.
Okay. Moving down into the rectum and anal canal, the arterial supply story changes again. The defining feature here seems to be redundancy.
It is remarkably redundant, yes. We've already mentioned the superior rectal artery, which is the continuation of the IMA supplying the upper rectum, but the lower rectum and anal canal receives significant additional supply from branches of the internal iliac artery system. Specifically, we have the middle rectal arteries, which are somewhat variable but usually present, and the inferior rectal arteries. Both of these typically arise either directly or indirectly from the internal pudendal artery, which itself is a major branch of the internal iliac artery. This gives the rectum a dual, sometimes triple massive blood supply from both the IMA and the internal iliac systems.
And this redundancy is essentially the surgeon's salvation during a low anterior resection for rectal cancer, isn't it?
Absolutely. The sources explicitly highlight this point. Because of this rich, overlapping triple arterial supply, the standard surgical division of the superior rectal artery, high ligation of the IMA, and often the middle rectal arteries during a low anterior resection, which is necessary to get enough length and mobility on the rectal stump, does not typically result in ischemic necrosis of the remaining rectum. The robust supply from the intact inferior rectal arteries is usually sufficient to keep the distal stump viable.
That's critical to understand. Now let's look at the venous drainage. It generally mirrors the arteries, but the really critical point here is the portal systemic junction it creates down low.
That's right. Venous return from the right side of the colon, ascending transverse, collects into tributaries that form the superior mesenteric vein, SMV. The left side, descending, sigmoid, drains into the inferior mesenteric vein, IMV. Both the SMV and the IMV ultimately drain into the portal vein, carrying nutrient-rich but deoxygenated blood directly to the liver for processing. This is the portal venous system.
But the lower rectum and anus are different.
Exactly. The crucial difference is in the lower rectum and anal canal. The veins here, the inferior rectal veins and usually the middle rectal veins, drain laterally into tributaries of the internal iliac vein. The internal iliac vein is part of the systemic circulation, returning blood directly to the inferior vena cava and then the heart, bypassing the liver.
So the meeting point of the superior rectal vein, draining upwards to the portal system, and the inferior and middle rectal veins, draining laterally to the systemic system, is where pathology, like varices, can manifest.
Precisely. This junction, primarily in the submucosa of the upper anal canal and lower rectum, represents a classic portosystemic anastomosis. If a patient develops severe liver disease, like cirrhosis, leading to portal hypertension, the blood flow backs up in the portal system. It seeks alternative routes back to the heart. This low rectal anal junction is a prime location for that backed up portal blood to shunt into the systemic circulation via these connections. The result is the engorgement and dilation of these veins, forming varicosities which we clinically recognize as internal hemorrhoids when they become problematic, especially those associated with significant systemic venous congestion or portal hypertension.
Okay. Finally, for this section, let's track the lymphatic highways. Lymph drainage is absolute critical for cancer staging, and it generally follows the vascular supply routes across 4 fairly well-established nodal stations.
Yes, understanding the lymphatic drainage is paramount for oncological surgery. The flow is sequential. The very first nodes encountered are the tiny epiploic nodes located right on the bowel wall, just below the peritoneum, sometimes within the appendices epiploicae themselves.
Step 1.
Step 1. These then drain to the paracolic nodes. Para, meaning alongside these nodes, lie adjacent to the marginal artery of Drummond, right along the mesenteric border of the colon. From there, lymph flows to the intermediate nodes. These nodes cluster along the primary named colic vessels, the ileocolic, right colic, middle colic, left colic, and sigmoid arteries.
Following the arteries centrally.
Exactly. And finally, the fourth level comprises the main or principal nodes. These are the large clusters of nodes located right at the origin of the major vessels around the base of the SMA and the IMA near the aorta. From these principal nodes, lymph ultimately flows upwards towards the cisterna chyli, the main collecting duct for lymph from the lower body.
Now, the rectum and anal canal have a fascinating and surgically critical differential drainage pattern based on their position relative to that all-important dentate line.
This distinction is absolutely crucial for staging and treating rectal and anal cancers. The upper and middle parts of the rectum generally follow the expected pathway. Lymph drains upwards along the superior rectal vessels, follows the IMA pathway, eventually reaching the para-aortic principal nodes, and then the cisterna chyli.
Okay, standard hindgut pattern.
Standard hindgut pattern. However, the lower third of the rectum gets more complex. It can drain upwards along the superior rectal vessels like the rest of the rectum, but it also has significant drainage pathways laterally, following the middle rectal vessels towards the internal iliac lymph nodes within the pelvis.
So 2 potential routes from the low rectum.
2 main routes, yes. But the most critical distinction happens below the dentate line. Any tumor or infection originating in the anal canal below the dentate line, in the somatically innervated zone, bypasses the entire abdominal and pelvic lymphatic system. Its lymphatic drainage goes directly via the inferior rectal lymphatics downwards and outwards to the palpable superficial inguinal lymph nodes in the groin.
Which means a patient with anal cancer might present with enlarged groin nodes, completely skipping the abdominal nodes.
Precisely. It's a completely different pattern of spread that dictates different staging investigations and potentially different treatment fields for radiation, for example.
All right, let's navigate the nervous system. Understanding the nerves, especially in the pelvis, is arguably where surgical mastery truly separates the expert from the merely competent technician. Our sources break it down into 4 interacting components: the intrinsic enteric nervous system, the overlying autonomic nervous system, ANS, the extrinsic sensory nerves, visceral afferents, and the somatic motor innervation. Let's start with the sympathetic system, typically thought of as the functional brake and the sphincter constrictor for the gut.
Right. The sympathetic nerve fibers that supply the gut originate from the intermediolateral cell columns of the spinal cord. For the midgut territory, remember, that's everything up to the splenic flexure. The preganglionic fibers arise from spinal levels T5 down through T12. For the hindgut territory, distal colon and rectum, they come from the upper lumbar segments, L1 and L2.
And their action in the colon and rectum is essentially twofold.
Primarily twofold, yes. They release the neurotransmitter noradrenaline, norepinephrine. This generally causes presynaptic inhibition of the enteric nervous system, effectively slowing down or stopping background peristaltic motility, the fight-or-flight response, diverting resources away from digestion. Simultaneously, and perhaps more importantly for function, sympathetic stimulation drives active contraction of the sphincters, the ileocecal valve separating the small and large bowel, and critically the internal anal sphincter. So sympathetics slow transit and promote continence by keeping the exit doors shut tight.
How does this complex sympathetic supply actually reach the deep pelvis to innervate the lower rectum, and how does it avoid damage during pelvic dissection like TME?
It's a complex pathway. The hindgut sympathetic supply travels initially via the lumbar splanchnic nerves down to the plexus around the aorta and the origin of the IMA, the inferior mesenteric plexus. Below this, fibers from the aortic plexus and the lumbar splanchnic nerves fuse to form the presacral nerves. This bundle, primarily sympathetic, descends over the sacral promontory into the pelvis. These presacral nerves then contribute significantly to the superior and inferior hypogastric plexuses, which lie on the pelvic side walls and distribute fibers to the pelvic organs, including the rectum and bladder. These delicate nerve plexuses run laterally, almost hugging the pelvic side walls and the fascia over the sacrum, placing them directly in the surgical field during the lateral and posterior dissection of a total mesorectal excision.
Makes sense why they're so vulnerable. Now, let's talk about the counterforce.
Right.
The parasympathetic system, this is the rest and digest system, the accelerator and the relaxation driver for defecation.
Yeah.
Exactly. This is the system that promotes propulsive activity and crucial sphincter relaxation. For the midgut, again, proximal to the splenic flexure, the parasympathetic innervation is conveyed by the vagus nerve, cranial nerve X, descending from the brainstem.
Standard gut innervation.
Standard for the upper gut. However, below the splenic flexure, the hindgut structures descending colon, sigmoid, rectum, upper anal canal receive their parasympathetic supply from a completely different source, pelvic splanchnic nerves. These nerves arise directly from the sacral spinal cord segments S2, S3, and S4.
These are often referred to collectively as the nervi erigentes because of their absolutely critical role in mediating penile erection, right?
That's correct. They carry the parasympathetic signals essential for vasodilation leading to erection. But functionally for the bowel, their action is to stimulate coordinated colonic propulsion, peristalsis, and crucially, to facilitate defecation by causing the relaxation of the internal anal sphincter, acting in direct opposition to the sympathetic input. Most of these parasympathetic fibers synapse directly within the intrinsic nerve plexuses like Auerbach's and Meissner's, located right there in the gut wall.
Okay, moving on to sensory and somatic innervation. Where do we actually feel things in the colon and rectum? What about pain?
Visceral pain, that sort of diffuse, poorly localized cramping or distension feeling you get from the colon, is transmitted by sensory nerve fibers, the visceral afferents, that generally travel back alongside the autonomic nerves. So sensations from the midgut travel back with a vagus nerve to the brainstem. Sensations from the hindgut are a bit different. The visceral afferent fibers have their cell bodies located back in the dorsal root ganglia of the spinal cord, specifically at the lumbar L2, L3, and upper sacral S1, S2 levels. Their fibers travel back towards the spinal cord alongside the sympathetic and parasympathetic nerves, which can sometimes lead to referred pain patterns.
But the upper anal canal, that anal transition zone, ATZ we mentioned earlier, seems to provide much more specific, fine sensory discrimination. This must be where the anatomy supports that sampling function for continence.
Absolutely. The genius of the ATZ lies in its incredibly rich and specialized sensory innervation. It's packed with specialized nerve endings that provide sensory input far beyond simple pain or stretch. The sources list several types. You have Golgi-Mazzoni bodies, which are thought to sense pressure changes, Meissner's corpuscles for detecting fine touch, genital corpuscles, which might sense friction, and Krauss's bulbs, which are sensitive to cold temperatures. The brain's integration of all this detailed sensory data coming from the ATZ is what allows the sphincter mechanism under conscious control to accurately classify the rectal contents, solid, liquid, gas, and make the appropriate decision about continence or evacuation.
Fascinating level of detail there. And just to wrap up the motor control side, the somatic nervous system, the voluntary part.
That's the direct conscious control. The external anal sphincter, being skeletal muscle, is supplied by the inferior rectal branch of the pudendal nerve. Again, S2, S3, S4 roots. The levator ani muscles, the main pelvic floor support, receive their primary innervation mainly from direct branches arising from the anterior rami of the S3 and S4 spinal nerves, with usually a lesser contribution from S2 as well. These nerves approach the muscle more from its pelvic surface.
Okay, let's bring all this anatomy into the shark focus of the surgical reality. Whether we're talking about a right colectomy or a left colectomy for cancer, there seem to be three absolutely non-negotiable core principles that guide not just the oncological resection, but also the success of the subsequent anastomosis. Let's unpack the first two: high ligation and ischemic demarcation.
Right. These are fundamental. High ligation is really the oncological mandate. It means deliberately identifying and dividing the main blood supply, the primary colic arteries like the iliacolic, right colic, middle colic, or IMA, as close as possible to their origin from the major contributing vessel, the SMA, or the aorta for the IMA. The purpose is twofold. It ensures the removal of the primary lymph node basin associated with that vessel, maximizing the chance of clearing microscopic metastatic disease.
Getting the apical node.
Getting the apical node, exactly. And second, ischemic demarcation is the practical, technical guide that follows from ligation. By ligating the vessels first, you interrupt the blood flow. Within minutes, you'll often see a visible line of demarcation appear on the bowel wall, a color change showing the transition from well-perfused bowel to ischemic bowel. This line clearly shows the surgeon the most appropriate, viable location for the bowel transection, ensuring the segment left behind has a robust blood supply for healing.
Okay, that makes sense. And the third core principle is the anastomosis itself, the crucial reconnection of the bowel ends. What are the three non-negotiable tenets for creating a successful leak-proof join?
You absolutely have to get these right. 1,
Okay.
the union must be completely tension-free. If you have to stretch or pull the two ends together, that tension compromises blood flow at the suture or staple line and dramatically increases the leak risk. You need enough mobilization to bring them together easily. No strain at all. 2, there must be a demonstrably rich vascular supply to both ends being joined. This is confirmed by seeing healthy, pink, bleeding edges after transection, guided by that ischemic demarcation we just talked about. Poor blood supply means poor healing. And 3, the connection must have mechanical integrity. For a hand-thrown anastomosis, that means accurate placement of sutures. For a modern circular stapled anastomosis, the surgeon visually confirms this by inspecting the 2 complete tissue rings, the donuts that are cut out by the stapler. Seeing 2 complete, intact rings confirms that the full thickness of the bowel wall from both ends was incorporated into the staple line. Missing tissue means a defect and a likely leak.
Okay, tenets locked in. Let's apply this to specific operations. Starting with right colon approaches, the traditional open method is often lateral to medial dissection for a right hemicolectomy. How does that proceed?
The classic lateral approach starts with an incision along the white line of Tolt. This isn't the structure itself, but rather the line of peritoneal reflection, where the ascending colon or cecum is attached to the posterior abdominal wall, the retroperitoneum. Incising this peritoneal reflection allows you to enter the correct avascular areolar plane. Dissection here involves gently lifting the colon and its mesentery medially, separating it from the underlying retroperitoneal structures. You absolutely must identify and protect Geroto's fascia, which covers the right kidney, and, most critically, visualize and preserve the right ureter as it runs down over the psoas muscle. As the dissection moves further medially toward the midline, the C-luke of the duodenum comes into view.
Okay. Now, the medial to lateral approach, which is often favored laparoscopically, flips that. It's a vascular-first strategy. What's the critical pitfall to avoid here?
Yeah, the medial approach starts centrally. It focuses on identifying and exposing the origin of the ileocolic pedicle, artery and vein, right where it branches off the SMA and SMV. The critical surgical hazard here is the second and third parts of the duodenum. The duodenum lies in extremely close proximity, often directly posterior or adherent to the base of the right mesocolon where these vessels originate. The surgeon must ensure that the duodenum is fully identified, carefully dissected free, and retracted safely away from its mesocolic attachments before any clamps are applied or any vascular ligation device is fired. Failure to do this is the primary mechanism for causing inadvertent iatrogenic injury to the duodenum or even the underlying head of the pancreas during the division of the ileocolic vessels.
A potentially catastrophic complication. Now, the decision point between performing a standard versus an extended right hemicolectomy that seems purely dictated by the oncological need for wider lymph node clearance, is that right?
Precisely. A standard right hemicolectomy typically involves ligating the ileocolic vessels and the right colic vessels, if present, and usually just the right branch of the middle colic artery, allowing preservation of the main middle colic trunk to supply the remaining transverse colon. An extended right hemicolectomy, however, is performed when you need a wider lymphatic clearance, perhaps for a tumor near the hepatic flexure or in the proximal transverse colon. This requires taking the entire middle colic artery and vein stump right at their origin from the SMA-SMV. This necessitates removing much more, or even all, of the transverse colon. After the vascular control is achieved, the surgeon then needs to manage the remaining attachments: the hepatocolic ligament connecting the hepatic flexure to the liver, and the gastrocolic ligament, part of the greater omentum attaching to the transverse colon. A decision needs to be made whether to remove the greater omentum en bloc with the specimen or to carefully dissect it off the transverse colon, which usually involves entering the lesser sac behind the stomach.
Okay, let's move across to the left colon approaches for a left hemicolectomy. The lateral mobilization seems similar initially, using the white line of Tolt on the left side.
The initial step is similar, yeah. Incising the left white line of Tolt to mobilize the descending and sigmoid colon medially. But the anatomical hazard changed significantly on the left. As you retract superiorly and medially, you again expose Geroto's fascia over the left kidney, but now you must identify and protect the left ureter, which typically crosses the iliac vessels near the pelvic brim, often close to the origin of the IMA. Perhaps the most technically challenging part of a left-sided mobilization is dealing with the splenic flexure. It's usually much higher, more acutely angled, and more fixed by ligaments like the splenocolic ligament than the hepatic flexure. Great care must be taken during its mobilization due to the very close proximity of the spleen. Aggressive traction or inadvertent injury can easily cause a splenic capsular tear and significant bleeding.
A dreaded complication. And the medial to lateral approach on the left, it uses the inferior mesenteric vein, IMV, as the initial roadmap.
That's a common strategy, especially laparoscopically. The IMV is often the first major vascular structure clearly identified. It's usually found running vertically, just to the left of the ligament of Treitz, often near the inferior border of the pancreas. An incision is typically made in the peritoneum just medial to the vein. Identifying and gently retracting or sometimes dividing the IMV superiorly helps the surgeon expose the underlying inferior mesenteric artery, IMA trunk, closer to its aortic origin for the high ligation. A key technical tip for gaining extra length on the left side, especially for low anastomosis, is that additional mobility can often be achieved by dividing the IMV flush with the inferior border of the pancreas and then continuing the mobilization of the distal transverse mesocolon off the retroperitoneum.
Good tip. This discussion of vessel ligation brings us naturally to those areas of highest clinical risk for ischemia, the watershed areas of potentially poor collateral circulation. These are the two famous critical points every colorectal surgeon must have memorized.
Absolutely critical points. The first is Griffith's critical point, located right up at the splenic flexure. This is the physiological meeting point, the anastomosis site, where the territory supplied by the most distal branches of the SMA, via the middle colic artery, meets the territory supplied by the IMA, via the left colic artery, through the marginal artery. Because the collateral connection via the marginal artery can sometimes be tenuous or absent right at this flexure, this specific region is often the most susceptible part of the colon to developing ischemic colitis, especially in low-flow states like shock or following aortic surgery that might compromise the IMA origin.
Okay, Griffith's point at the splenic flexure, and the second critical point is much further down, in the sigmoid-rectal transition zone.
That's Sudek's critical point. This point refers specifically to the anastomosis between the very last sigmoid arterial branch from the IMA and the descending branches of the superior rectal artery, the continuation of the IMA. Historically, there was concern that ligating the IMA proximal to the origin of the left colic, a true high ligation, might compromise this distal anastomosis and lead to ischemia of the upper rectum if the marginal artery connection from the sigmoid branches wasn't robust. While clinically significant ischemia here after a proper high IMA ligation is actually quite rare due to good collateral flow, it remains an area surgeons are aware of, ensuring the proximal rectal stump appears well perfused before creating an anastomosis.
Okay, noted. Let's quickly cover appendicectomy before moving to the rectum. The gold standard now is overwhelmingly laparoscopic, right?
Yes, the laparoscopic approach is highly standardized and generally preferred due to less pain, quicker recovery, and better visualization in obese patients, or cases of diagnostic uncertainty. It typically uses 3 small incisions, trocars. The appendix is identified and grasped. Retraction puts its mesentery, the mesoappendix, under tension. This allows the appendiceal artery, running within the mesoappendix, to be clearly skeletonized and divided, usually using surgical clips, energy devices like ligature, or sometimes sutures. Management of the appendiceal base depends on its condition. If the base looks healthy and viable, it's typically secured about 2 millimeters above the cacal pole, often using pre-tied surgical loops, endoloops. If the base itself is inflamed, necrotic, or frankly perforated, then an endomechanical stapler is usually used to transect the base flush with the cacal wall, ensuring a secure closure while taking extreme care to avoid narrowing or damaging the nearby ileocecal valve.
And the classical open technique, often via McBurney's point incision, how is the base managed there?
McBurney's point is classically defined as the point 1/3 the distance along a line from the anterior superior iliac spine to the umbilicus, although often the incision is just made over the point of maximal tenderness. In the traditional open technique, if the appendix base is healthy, it's often crushed with a hemostat clamp first, then ligated securely with a strong, non-absorbable tie, typically silk. The stump itself is often cauterized. Then, to prevent a potential mucocele from forming in the retained stump and perhaps reduce the risk of contamination, the ligated stump is frequently inverted or imbricated into the cacal wall using a purse-string suture placed around the base. This inversion step is often omitted in the modern laparoscopic stapled approach.
All right, now we move deep into the pelvis. The principles guiding rectal cancer surgery were fundamentally revolutionized by Professor Richard Heald's concept of the total mesorectal excision, or TME. This seems to be where we transition from just general mobilization to meticulous, precise fascial plane dissection.
Absolutely. TME wasn't just a new technique. It was a paradigm shift based on understanding embryology and fascial anatomy. Heald's critical realization was that the rectum and its surrounding fatty envelope, The mesorectum, which contains all the primary lymphatic drainage, blood vessels, and nerves relevant to the rectum, is completely enclosed by its own thin, distinct fascial layer, the fascia propria of the rectum. By meticulously dissecting outside this fascial envelope, staying within the correct embryological plane, often called heel-toli plane, the surgeon ensures the complete removal of the rectum and its entire draining lymphatic field as a single intact package. This minimizes tumor breach, drastically reduces local recurrence rates, and forms the absolute foundation of the modern oncological approach for a low anterior resection, LAR, for rectal cancer.
Before you can even begin that meticulous TME dissection, though, you first have to deal with the major vascular pedicle and critically identify and protect the ureters. Ureter identification seems like a non-negotiable prerequisite.
It is absolutely non-negotiable. You cannot proceed with major vessel ligation until the ureters are clearly identified and seen to be safe. The left ureter is particularly vulnerable during rectal surgery. If you're using a medial to lateral approach, starting near the IMA origin, the left ureter is typically found lying directly posterior to the superior rectal artery pedicle, crossing over the iliac vessels at the pelvic brim. If you're using a lateral to medial approach, mobilizing the sigmoid first, the surgeon usually finds the ureter crossing the pelvic inlet slightly more laterally, often just medial to the left gonadal vessels, testicular or ovarian. The crucial confirmation step is to gently observe the ureter's characteristic wave-like peristalsis ureter vermiculation. Seeing it wiggle confirms it's the ureter and not a blood vessel or fibrous band, which is a significant risk, especially in cases with inflammation or advanced tumors where the tissue planes can be distorted and scarred.
Okay, ureter identified and safe. Now you move to ligate the IMA, or its continuation, the superior rectal artery. Using that medial approach, where should the dissection plane be initiated relative to the pelvic nerves?
When using the medial approach to get to the IMA origin, the surgeon deliberately enters the presacral space anterior to the midline sympathetic nerve bundle, the hypogastric nerve plexus, or presacral nerves, that runs vertically over the sacral promontory. The IMA, or superior rectal artery, is then identified as it arches over the pelvic brim. It's then ligated and divided again. This must only be done after the left ureter's position and safety have been unequivocally confirmed, because the ureter can sometimes be dangerously tethered or pulled medially right against the IMA pedicle by adjacent inflammation or tumor infiltration.
Okay, vessels ligated, ureter safe. Now we enter the heartland of the TME dissection, following Heald's holy plane. There's that famous surgical mantra that perfectly captures the essence of this high-risk, high-precision separation.
The mantra is simple but profound. Remain on the yellow side of the white. The yellow side refers to the glistening, fatty tissue of the mesorectal envelope itself. That's what you want to be seeing on your specimen side. The white side refers to the distinct, glistening fascial layer covering the underlying structures, primarily the presacral fascia posteriorly and the pelvic sidewall fascia laterally, that must be left intact, undisturbed on the patient. This simple phrase encapsulates the entire principle. Take the yellow mesorectum, leave the white fascia behind, and by doing so, you preserve the critical nerves and vessels running just underneath that white fascia.
Let's detail the planes, starting with the posterior plane. The dissection proceeds anterior to the presacral fascia, covering the sacrum and coccyx.
Exactly. The posterior dissection involves gently lifting the intact mesorectum forwards, away from the sacrum. You're developing that plane between the back wall of the mesorectal fascia, fascia propria, and the glistening presacral fascia covering the bone. The greatest danger posteriorly is inadvertently violating this plane and dissecting deep to the presacral fascia. If the surgeon goes too deep, they risk encountering the incredibly dense, high-pressure network of presacral veins that lie directly on the bone. Bleeding from these veins can be torrential and is notoriously difficult to control. Furthermore, dissecting deep to the presacral fascia almost guarantees injury to the delicate sympathetic hypogastric plexus, which lies just under that fascia.
And there's a specific fascial landmark posteriorly, Waldeier's fascia, that helps guide the dissection down low.
Yes, as you dissect lower down in the presacral space, around the level of the S4 vertebra, you encounter a thickening of the retrorectal fascia called Waldeier's fascia. This dense fibrous band projects antero-inferiorly from the sacrum towards the rectum. Identifying and dividing this fascia correctly helps guide the posterior rectal dissection plane accurately down towards the pelvic floor muscles, levator ani.
Okay, now shifting around to the anterior plane. Here, the surgeon encounters another key fascial layer, Denonvillier's fascia.
Correct. Anteriorly, the TME plane lies between the anterior wall of the rectum mesorectum and this distinct fascial layer, Denonvillier's fascia. This fascia acts as a septum, separating the extraperitoneal rectum from the genitourinary structures located just in front of it. In men, Denonville's fascia separates the rectum from the prostate gland and the seminal vesicles. In women, it separates the rectum from the posterior wall of the vagina and the rectovaginal septum. The critical decision here is whether to dissect anterior to Denonville's fascia, preserving it on the GU structures, or posterior to it, taking it en bloc with the rectal specimen. This decision is purely oncological. If the anterior tumor margin is clearly away from the fascia, preserving it helps protect sexual and urinary function. However, if the tumor is anteriorly located and potentially involving the fascia, then Denonville's must be included in the resection specimen to achieve a clear margin.
And the dissection in all these planes continues downwards until the pelvic floor muscles, the levator ani, are finally encountered at the bottom of the pelvis. This brings us to the greatest functional hazards of TME, damage to the autonomic nerves that run along these very dissection planes.
This is where the stakes are highest functionally. The hypogastric nerves, carrying primarily sympathetic fibers, run laterally, descending into the pelvis just caudal to the sacral promontory, often within or just deep to that white presacral fascia laterally. They're incredibly vulnerable to direct injury, traction injury, or thermal damage from energy devices during the posterior and lateral dissection. Damage to the hypogastric nerves can lead to significant bladder dysfunction, particularly problems with bladder neck closure and storage, causing urinary retention. The risk is cited anywhere between 7 and a staggering 59% in various series. In men, it also commonly leads to ejaculatory dysfunction, including failure of emission or retrograde ejaculation. Risk cited around 32 to 42%.
Devastating consequences. And the nervi erigentes, the parasympathetic fibers S2, S4, essential for erection, are perhaps equally, if not more, precarious.
They are extremely vulnerable too, perhaps even more so functionally for sexual health. The nervi erigentes, carrying the parasympathetic supply, tend to run a bit more anteriorly and laterally, closer to the pelvic sidewalls, as they sweep forward to contribute to the neurovascular bundles and the paraprostatic plexus in men. They are particularly at risk during the deep anterior and lateral dissection, especially if Denonville's fascia needs to be resected. If the surgeon injures the parasympathetic nervi erigentes, but manages to preserve the sympathetic hypogastric nerves, the patient typically suffers primarily from erectile dysfunction. However, more extensive damage, particularly involving the paraprostatic plexus during the dissection near the prostate apex, often results in both severe erectile impotence and a neurogenic flaccid bladder due to loss of parasympathetic input required for bladder contraction. The overall risk of some degree of sexual dysfunction after TME is unfortunately very high, cited up to 100% in some older series, although nerve-sparing techniques have improved this somewhat.
It certainly sounds like the traditional abdominal TME approach faces its greatest challenges in that very deep, narrow distal part of the rectum, especially in male patients, making nerve preservation incredibly difficult down low. This difficulty seems to have been a major driver for the development of modern transanal surgical techniques.
Absolutely. The limitations of visualization and instrumentation in the deep, narrow pelvis with the traditional top-down approach led directly to innovation. First came transanal endoscopic microsurgery, and its more recent iterations like transanal minimally invasive surgery, TAMIS. These techniques utilize specialized ports and high-definition optics inserted directly through the anus. They allow surgeons to perform highly precise, full-thickness local excisions of benign polyps or, more importantly, early-stage, low-risk rectal cancers, like T1 inserted tumors, located in the mid to lower rectum. The magnified view often allows for better visualization of tissue layers, potentially leading to lower recurrence rates and higher rates of clear resection margins compared to older transanal excision methods, and crucially, allowing many patients to avoid a major proctectomy altogether.
And the ultimate adaptation of this bottom-up philosophy seems to be TTME, transanal total mesorectal excision.
TTME is the logical next step, applying the transanal platform to the entire TME procedure. It's essentially a bottom-up TME. One surgical team works transanally, dissecting upwards from the level of the planned distal transection margin, performing the TME dissection from below. Simultaneously, another team works abdominally, usually laparoscopically or robotically, dissecting downwards in the standard fashion. The two teams meet somewhere in the mid-rectum. This dual-access strategy dramatically improves visualization and access to the incredibly challenging distal third of the rectum, especially in obese male patients with narrow pelvis. The goal is to simplify the most difficult part of the TME, theoretically leading to better quality TME specimens with clearer distal and circumferential margins and potentially better nerve preservation right down low.
Okay, let's shift focus right down to the anal canal and dissect the anatomy of infection, specifically perianal and perirectal abscesses and fistulae. The sources emphasize that these almost universally originate from infection within the deep anal glands, which are located in the intersphincteric space between the internal and external sphincters, and whose ducts open into the anal crypts right at the level of the dentate line.
That's the key starting point. Infection starts in those glands within the intersphincteric space. Where the infection then tracks determines the location of the abscess. The sources highlight 3 potential spaces where abscesses most commonly form, as shown in Figure 60.9 in our materials. First, and perhaps most common and simplest to drain, is the ischioanal space, also called ischiorectal space. This large, fat-filled space lies lateral to the external sphincter complex. Second, the infection might remain localized within the intersphincteric space itself. From there, it contracts cephalad upwards, above the pelvic floor muscles to form a dangerous supralevator abscess, or contract caudally downwards between the sphincters to present as a small abscess right at the perianal skin margin. And third, the infection can tract directly upwards from the intersphincteric space, or sometimes spread from an ischioanal abscess into the supralevator space, the potential space located above the levator any musculature, but below the pelvic peritoneum. These are deep, complex abscesses requiring careful drainage, often image-guided.
What about those high-risk postanal spaces mentioned? Where do they fit in?
The postal spaces are important, particularly for understanding horseshoe abscesses. There's a potential deep postal space located superior cephalad to the anachythial ligament, which connects the coccyatics to the anus. Infection tracking into this deep space from a posterior midline crypt is the classic origin of a horseshoe abscess, which can then spread circumferentially around the posterior aspect of the anal canal, often extending into both ischioanal spaces. There's also a more superficial postal space located caudally to the ligament.
Okay. Now, after an abscess drains, either spontaneously or surgically, it often leads to the formation of a chronic cryptoglandular fistula, an abnormal tract connecting the internal opening, the original infected crypt at the dentate line, to an external opening on the perianal skin. Surgeons famously use Goodsall's rule as a kind of geometrical prediction tool to help locate the likely internal opening based on where the external opening is. What are the stipulations of that rule?
Goodsall's rule is a remarkably useful clinical predictor, although not infallible. It basically divides the anal verge into an anterior half and a posterior half, using an imaginary transverse line. The key principle is, if the external opening is located posterior to that transverse line in the back half, the underlying fistula tract will almost always take a curvilinear, often horseshoe-like path to connect to an internal opening located in the posterior midline of the anal canal, right at the dentate line.
Okay, posterior external means curved tract to posterior midline internal. What about anterior openings?
If the external opening is anterior to that transverse line in the front half, the rule states that the fistula tract typically follows a simple, direct radial or perpendicular path straight into the anal canal, connecting to the nearest crypt.
That sounds almost too straightforward to be universally true. What are the key exceptions or caveats a surgeon absolutely must remember?
There are 2 main exceptions you have to keep in mind. First, if an anterior external opening is located more than 3 centimeters laterally from the anal margin, it often breaks the rule. These long anterior tracts usually behave like posterior ones, meaning they're likely to have a curved path originating from the posterior midline after all. The second major exception is that Goodsall's rule really only applies reliably to common cryptoglandular fistulae, those arising from infected anal glands. Fistulae caused by other underlying pathology like Crohn's disease, HIV infection, tuberculosis, previous trauma, or malignancy often form complex, atypical tracts that completely ignore Goodsall's rule.
Very important distinctions. Okay, moving to treatment. The initial phase for an acute abscess is usually simple incision and drainage. If a fistula persists, sometimes a seat and drain is placed initially to allow inflammation to settle and keep the tract patent. But for definitive fistula treatment, the surgeon has to balance eradicating the tract against the potentially catastrophic risk of causing fecal incontinence by damaging the sphincter muscles. How do surgeons decide when it's safe to perform a fistulotomy?
Fistulotomy, which means laying open the entire fistula tract from internal to external opening. Allowing it to heal from the base up is technically the simplest and generally has the highest success rate for cure. However, because it involves dividing the overlying sphincter muscle, It carries a definite risk of incontinence. Therefore, fistulotomy is generally reserved only for tracts that involve minimal sphincter muscle. This typically means fistulae that are entirely subcutaneous, below the sphincter, purely intersphincteric, running only between the internal and external sphincters, or low transsphincteric fistulae, crossing the sphincter complex, that involve less than roughly 30% of the external sphincter muscle mass. In these cases, particularly in men who tend to have stronger sphincters, the risk of significant incontinence after fistulotomy is considered relatively low, and success rates are high.
But if the fistula tract is high, complex, or involves a significant portion of the external sphincter, or if the patient is female, generally lower sphincter pressures, or already has some baseline continence issues, then the risk of incontinence with fistulotomy is deemed too high. In these cases, sphincter-preserving techniques are mandated. What are the main options there?
This is where fistula surgery gets much more complex and nuanced. The goal is to close the internal opening and eliminate the tract without cutting the sphincter muscle. Several techniques exist with varying success rates. One common approach is using an endorectal advancement flap. Here, the surgeon creates a flap of healthy rectal mucosa, submucosa, and sometimes a bit of muscle, starting above the internal opening. This flap is dissected free, the internal opening is closed, and then the flap is advanced down to cover the repair site, bringing a fresh blood supply and relying on the redundancy of the rectal tissue to seal the defect from the inside. Another major sphincter-preserving technique, particularly popular for transsphincteric fistulae, is the ligation of intersphincteric fistula tract, or lift procedure. As the name suggests, lift involves making an incision in the intersphincteric groove, carefully dissecting within that plane to identify the fistula tract as it passes between the internal and external sphincters. The tract is then ligated, tied off, proximally near the internal opening and distally, and the intervening segment is often excised. The idea is to interrupt the infectious pathway right in the intersphincteric space without damaging the external sphincter.
Okay, complex strategies for complex problems. Finally, let's touch on hemorrhoid management. We know the anal cushions are classically located at 3, 7, and 9 o'clock, or right anterior, left lateral, right posterior anatomically. What are the key treatment modalities, distinguishing between internal versus external or lower versus higher grades?
Right. For symptomatic but less severe grade 1 or 2 internal hemorrhoids, those that bleed but don't significantly prolapse, we always start with conservative measures: dietary modification, high fiber, fluids, avoiding straining. If those fail, simple office-based procedures can be very effective. Rubber band ligation is probably the most common and effective for grade 3 internal hemorrhoids. A small rubber band is placed around the base of the hemorrhoid cushion, well above the dentate line. This cuts off blood supply, causing the hemorrhoid to thrombose, fibrose, and fall off. The key is placing the band high enough in the insensitive zone to avoid severe pain. Sclerotherapy, injecting a scarring agent, and cryotherapy, freezing, or other, perhaps less common or higher risk, alternatives for internal hemorrhoids.
Okay, but for more advanced, prolapsing grade the 3rd or HABA hemorrhoids, or for significantly symptomatic mixed internal and external hemorrhoids, those conservative measures usually aren't enough. Excisional haemorrhoidectomy becomes necessary. What's the key anatomical principle during that excision?
When performing an excisional haemorrhoidectomy, the technique must be meticulous to preserve function and, crucially, prevent postoperative anal stenosis, narrowing. The dissection must remain strictly superficial to the underlying internal and external sphincter muscles. The hemorrhoidal column, prolapsing cushion and overlying mucosanoderm, is carefully lifted off the surface of the underlying internal anal sphincter muscle. The dissection proceeds upwards until the vascular pedicle feeding the hemorrhoid is identified. A strong suture ligature is then applied directly to this pedicle, high up near its origin, to achieve secure hemostasis. The redundant hemorrhoidal tissue is then excised. The main difference between techniques lies in how the resulting defect is managed. The classic Milligan-Morgan technique leaves the defects open to heal by secondary intention, granulation. The Ferguson technique involves closing the defects primarily with sutures. Regardless of the closure technique, the single most crucial anatomical awareness point during excisional haemorrhoidectomy is to minimize the amount of normal anoderm, the sensitive skin just inside the anal verge, that is resected along with the hemorrhoid tissue. Excessive removal of anoderm is the primary cause of debilitating postoperative anal stenosis.
We have covered an immense amount of anatomical ground, effectively mapping the entire colorectal surgical landscape from the cecum down to the anus. Let's try to synthesize this by quickly reviewing the critical anatomical hazards, those key structures that a master surgeon is constantly almost subconsciously, tracking during operations in specific regions.
Okay, a quick hazard review. During surgery on the ascending colon, or cecum, like a right hemicolectomy, the primary structures constantly at risk are the duodenum, medially, and the right ureter, posteriorly. You also need to be aware of the proximity of the liver and right kidney.
Moving across the transverse colon.
Transverse colon surgery brings the stomach, posteriorly via the lesser sac, and especially the spleen, at the splenic flexure, into the high-risk zone.
Descending and sigmoid colon.
On the left side, the key structures to protect are the left ureter, especially across the iliacs, the left garnatal vessels, and the major iliac vessels themselves, lying just deep to the sigmoid mesentery root.
And then down into that high-risk, functionally precarious pelvic dissection for the rectum and anus.
This is the minefield. Operating on the rectum puts the left ureter again, the iliac vessels, the hypogastric nerves, sympathetic plexus posteriorly, the nervi irrigantes, parasympathetic nerves anterolaterally, the bladder, and the prostate seminal vesicles anteriorly in men, or vagina interiorly in women, all at extreme risk. Right down to the anus itself, the primary structural hazards are preserving the external sphincter muscle and maintaining the integrity of the perineal body, the central fibrous support between the anus and vaginal scrotum.
That's a sobering list. We must also quickly revisit those critical surgical landmarks and technical tips that directly translate this anatomical knowledge into surgical precision.
Okay, key tips. For a right hemicolectomy, always remember the complete mobilization of the duodenum is key before tackling the vessels. Mobilizing it fully can also help lift the pancreatic head slightly to better expose the origin of the middle colic vein, but safety first. Always mobilize and definitively protect the duodenum before ligating the ileocolic pedicle.
Left colon tips.
For left colon work, especially laparoscopically, utilizing steep Trendelenburg positioning combined with a significant left side up, right tilt, provide essential gravitational auto-retraction, pulling the small bowel out of the way. And remember, dividing the inferior mesenteric vein, IMV, high up, right at the inferior border of the pancreas, can often provide crucial extra centimeters of colonic length needed for a tension-free low anastomosis.
And for TME, the core principle comes back to preserving those life-altering functions.
Absolutely. For TME, the guiding light remains. Stay on the yellow side of the white, keep your dissection right on the glistening surface of the mesorectal fat, yellow, to preserve the underlying white presacral fascia and the autonomic nerves beneath it. And always visualize the left ureter, confirming its peristaltic formiculation before any major vascular ligation is performed, especially the IMA.
Okay, let's try and tie all these massive anatomical concepts together now by considering perhaps the most challenging common clinical scenario presented in our sources. A hypothetical 49-year-old male who presents with a biopsy-proven adenocarcinoma. It's staged as T2N0, so no involved nodes yet, but the lesion is a sessile polyp located extremely low in the rectum, right down at the anorectal junction. Critically, the preoperative MRI suggests there is significant concern about the tumor potentially being very close to or even involving the mesorectal fascial margins circumferentially.
Right. This is a classic challenging scenario. A T2N0 tumor wouldn't automatically mandate upfront surgery if the margins were clearly safe. However, the N0 status combined with the sessile nature and, most importantly, that significant concern about the circumferential resection margins, CRM, based on MRI, pushes this into a higher risk category for local recurrence if treated with surgery alone.
So what's the standard management approach recommended in this situation, according to our sources?
Given the N0 status, but the very real concern about achieving a negative CRM, the standard recommendation would typically be to consider neoadjuvant preoperative therapy. Specifically, a long course of combined chemoradiation therapy, CRT. This usually involves delivering a high dose of external beam radiation, typically in the range of 4,500 gray, CHV, up to 5,040 gray delivered in daily fractions over 5-6 weeks, concurrently with a radiosensitizing chemotherapy agent like 5-fluorosil-5-FU or its oral prodrug capecitabine. The primary goal of this neoadjuvant CRT is to shrink the tumor, downsize it, and sterilize the surrounding tissues, pulling the tumor away from that threatened surgical margin and thereby increasing the chances of achieving a complete R0 resection, microscopically clear margins, at the time of subsequent surgery and reducing the risk of local recurrence.
Okay, but what if the tumor fails to respond adequately to the chemoradiation, or if the margin is deemed definitively compromised right from the start, making even post-CRT resection unlikely to be clear? What's the alternative, more radical surgical option discussed?
If achieving a clear margin with a sphincter-sparing low anterior resection seems impossible, even after considering neoadjuvant therapy, then the ultimate radical procedure required for cure is the abdominal perineal resection, APR, sometimes specified as an extra levator APR, ELAPE, depending on the extent of pelvic floor involvement.
Explain the key steps for the APR in this context, focusing on the high legated anatomical requirements.
Because the tumor is right down at the anorectal junction, an APR involves removing the entire rectum, the anal canal, the sphincter complex, and a cylinder of surrounding perianal tissue and blobfish. There is no possibility of sphincter preservation. The patient will require a permanent end colostomy. Abdominally, the surgeon performs a complete indomitable crust, total mesorectal excision, TME, exactly as we discussed before, dissecting down meticulously within the holy plane all the way to the pelvic floor muscles, levator ani. Oncologically, it's crucial to perform a high ligation of the inferior mesenteric artery, IMA, right near its aortic origin to ensure maximum harvest of the draining lymph nodes.
Okay, the abdominal part is essentially a TME taken all the way down. The real complexity and morbidity then culminates in the perineal stage of the APR. What are the major anatomical challenges down there?
The perineal dissection is the defining part of the APR. The surgeon typically makes a wide, elliptical, or circular incision in the perianal skin well outside the palpable external sphincter muscle. The dissection then proceeds upwards, deep into the ischial fat, aiming to take a wide cylinder of tissue around the anal canal. You dissect circumferentially along the outer surface of the external sphincter complex until you reach the level of the levator ani muscle sling. To achieve a truly clean, wide resection of the pelvic floor attachment, especially if the tumor is very low or involves the levators requiring an ELAPE approach, the coccygiox is often surgically removed. Removing the coccygiox provides better access and serves as a posterior landmark, guiding the surgeon to the correct plane for dividing the levator muscle insertions for the pelvic sidewalls. The surgeon then circumferentially divides the levator ani muscles as far laterally as possible, freeing the entire anorectal cylinder from its pelvic floor attachments. This allows the entire specimen, rectum, anus, sphincters, surrounding tissue, to be delivered out through the perineal wound, meeting the abdominal dissection from above.
And the final significant anatomical hurdle after removing that entire cylinder is managing the large, empty pelvic dead space that's left behind.
Yes, this is a major source of potential postoperative morbidity after APR. The removal of the rectum, anus, and often a significant portion of the levator muscles leaves a large, non-collapsible pelvic dead space. This space is prone to collecting fluid, seroma or hematoma, which can easily become infected, leading to chronic pelvic sepsis, abscess formation, or persistent perineal sinus tracts that fail to heal. Therefore, meticulous closure of this pelvic dead space is critical. This usually involves attempting to close the remaining pelvic floor muscles, levators if possible, followed by careful, multi-layered closure of the perineal subcutaneous tissues and skin, often with placement of drains. However, especially after wide ELAP resections, or if the perineal wound is compromised, for example, after radiation, simple closure may be inadequate or likely to fail. In these high-risk situations, reconstruction often requires the transposition of healthy, well-vascularized tissue into the pelvis to obliterate the dead space and promote healing. This typically involves creating myocutaneous interpositional flaps, mobilizing muscle and overlying skin fat based on a reliable blood supply. Common options include using the erectus abdominis muscle, VRAM flap, the gracilis muscle from the thigh, or sometimes gluteal flaps, swung into the pelvis to fill the defect and provide a robust, infection-resistant closure.
That really brings us full circle, underscoring the profound connection between detailed anatomy and complex surgical reconstruction. This has been an incredibly deep dive. The sheer depth of knowledge required for true mastery in colorectal surgery is just astounding, demanding simultaneous focus on macro-level vessels and organs, specific fascial planes, and even microscopic sensory corpuscles in the anal canal.
It's truly fascinating, isn't it? How the ultimate functional success of many of these incredibly complex procedures isn't really based on how much tissue you manage to cut out, but rather on the intellectual respect and meticulous care paid to preserving these specific, often delicate embryological and fascial planes, like healed Tolle plane, Denonvillier's fascia, the presacral fascia, protecting the hypogastric nerves. Disregarding these planes, especially when working deep in the confines of the narrow pelvic box, is what leads directly to those permanent, life-altering functional tragedies.
So listening to all this intricate detail, especially around the pelvic nerves, it raises a final provocative question for you, the learner, to perhaps explore further. Given the unfortunate persistence of significant functional deficits like impotence, bladder paresis, and ejaculatory failure that can still occur despite these highly detailed anatomical roadmaps and even with the highest levels of current surgical skill, how will emerging technologies like advanced preoperative imaging, intraoperative augmented reality navigation, and personalized 3D anatomical mapping continue to refine surgical dissection even further? Will they finally allow us to reliably visualize and minimize injury to those critical, fine autonomic nerves, like the nervi erigentes, that still seem to remain some of the most elusive and vulnerable structures deep within the human pelvis?
That precise boundary between what we know exists anatomically and what we can consistently and reliably protect surgically in every single patient that really is the next frontier for the future of this field.
A fascinating thought to end on. Thank you for joining us for this exceptionally detailed exploration on the deep dive. We'll see you next time.